Most of you have seen this slide before, but what we know about your community is that it's growing slowly, about almost 3% over the last 7 years. But 100% of the growth that has occurred in the community has occurred as a result of the aging of the population. So the 65 plus population is the population that's growing. We actually saw a decrease in the number of people under the age of 65 during that time frame, about 3% decrease. Today, the population 65 plus represents about 27% of the total. That makes you one of the older communities in the state. The oldest community in the state today is Port Townsend, Jefferson County, with over 30% of their residents over the age of 65. And we think that you will be there by about 2030. And why that is really important is because seniors use health care at about 3 to 5 times the rate of people under 65. So even though the community is growing slowly, we expect significant increases in demand for services simply because of the aging of the population. What I'm going to just say here is on any given day, about 10 residents of your district are hospitalized in some hospital, either in Oregon or Washington. When we take a look, if we back out the kinds of things that you're not going to do, and we back out the fact that only about 70 to 80 babies are born a year to residents of the district, that means it's too small of a number. We don't have any hospital in our state that purposefully delivers babies when the community's numbers are that low. It's just too small. You're talking about probably 50 to 60 babies a year, 1 a week. It's hard to maintain skills and staffing and on-call anesthesia and those kinds of requirements for that number of births. But you're still seeing about 25 to 30% of all of those discharges, even when we look at the things that you can't do, OB, those kinds of issues. And you are dominating the market in these observation type patients. So you've got about an 80 to 90% market share of those. Those are patients that may stay overnight, may stay 23 hours, but you're observing them and they're deemed not to require hospitalization. And then you have a very high percentage, I think that number was in excess of 95% for swing bed patients. So patients that were hospitalized and now need, or even, I don't know if you've got contracts that allow you to admit someone directly to the swing bed, but you're seeing those patients that need some kind of stabilization or post-acute services before going home. ED visits have been going down for district residents. I see that as a very good thing. It tells me that the efforts that the district has had around recruitment and retention of providers has helped. We see really high emergency room use rates when there's not enough primary care in a community. And the fact that your numbers have gone down some in the last 5 years suggests that you've been able to meet community need through your primary care. What we have seen is really dramatic increases in outpatient use, and I'll talk about that again very quickly. That's the trend. Less people are being hospitalized and more people are being cared for on the outpatient side. For example, endoscopies. So even though the district is growing very slowly, you can see between 2014 and 2017, the number of endoscopies for residents of the district, again, regardless of where they got that care, went from about 460 to 625. And by 2017, you were performing the vast majority of those, about 85%. So the community relies on you for that kind of diagnostic care. Again, about 1,700 outpatient surgeries were performed on district residents, and about 2,000, more than 2,000 in 2017. So again, we're seeing some nice upward trends. That's what I would expect to see on the outpatient side. Your market share, there's opportunity for increased growth, but your market share actually increased by about 300% on those outpatient surgeries. Mammography volumes totally flat between 14 and 17, but your market share, the number of women that came here for their mammography increased from about 40% to 70%. Those are a lot of bodies coming through your facilities on any given day, and we expect to see that trend just simply continue at an accelerated rate into the future. And then we have some new data where we looked at the prescriptions written by KVH Family Medicine, about 50,000 in 2018. So that number was a surprise to me. It's a large number of prescriptions. And about 60% were filled out of the community, and I understand that that's at the preference of the patient as to where those get filled. So the majority of people are leaving the community to get their prescriptions filled, or were in 2018. Any questions so far? We also took a look at the kinds of services that the community, the data tells us the community needs. Wound care, again, you're doing a nice job in wound care. Your market share, the volumes of wound care increased pretty significantly from 2014 to 2017. Dental, I'm sure a lot of you have that data on dental, but the federal government has determined that the county, the entire county, is considered a shortage area for dental services, and they've said the same thing about mental health services. So those two areas are areas where they say there's simply not enough providers to meet community demand. The Columbia Gorge, so all the hospitals in the Gorge came together in 2016. They did a community health needs assessment, and the #1 need that they identified for healthcare was dental services. And about, it's the 5th most common reason for an ED visit at your hospital is related to dental, or was related to dental when we collected this data. Local nursing home is closed. You were early in that process. We have seen a lot of rural communities lose their nursing homes, but it really means that a lot of families are attempting to care for their elderly family member at home and needing more support services. And behavioral health. So the state, our state has said that we are going to integrate behavioral health into primary care very quickly. Again, you folks were early on in that process. Good morning. Good morning. Sorry. That's okay. Glad to have you into the process very early on, and you have done that. And what you're seeing is you're already full. And what I understand is that your providers are full in this area, and you're experiencing increasing wait times again. And then most of you are aware of this, but after we looked at all the data, we projected into the future the demands that residents will have. We didn't assume increasing market shares. We said, if you continue at your current rates, what kind of facilities are you going to need in this community? We determined you're going to need at least 7 to 8 inpatient beds to care for swing bed patients, acute patients, and also to make sure you have the capacity to surge during times of peak census, flus, natural disasters, those kinds of things. The state is really today encouraging hospitals to look at surge capacity. 3 operating rooms, three operating/procedure rooms are needed to accommodate volumes. Our recommendation was that you consider adding a 4th room for efficiency. One of the things, again, that we are healthcare insurance, the federal government is really saying, how can you drive down costs, continue to improve outcomes, and drive down costs? And one of the ways we can do that in the emergency room is to be as efficient as possible, to turn those rooms over and to have multiple rooms going so that we're not going into the evening with surgeries and those kinds of things. And that 4th room will give you that flex capacity. And also, I'm jumping ahead a little, but one of the things we heard from the community is that they want to stay locally for more kinds of care, and this would allow visiting specialists to come into the community. So short stay areas, we also think you need some chairs, some spaces to manage patients that come in on a very short stay basis for things like hydration, wound care, dressing changes, those kinds of things. Again, we expect those volumes to go up pretty dramatically in the next 5 to 7 years. And then because the facility is old, the acute care portion of the hospital is about 70 years old, what we found is that you no longer meet the requirements for square footage in the patient rooms and in your operating rooms. And so you're limited in the kinds of things you can do, the kinds of patients you can treat, simply because the spaces don't allow for the newer technology and some of the other requirements that the those guidelines, those FGI guidelines require. Those are what the state of Washington uses, and they're really national guidelines about the kinds of spaces that have to be in place at a hospital. We also surveyed the community back in 2017-18. We completed actually 460 surveys, and we did 6 focus groups where about 75 people attended those groups. And here's the key takeaways. Here's what they told us. Be careful on that population is the first thing they said to us. We think this community is going to grow faster than some of the data suggests it is, and that would just put more pressure on the facility if that's accurate. About 70% told us that they get their primary care here in Goldendale, and a lot, about 85%, told us that if they had an ED visit in the past year, they had come to you for that. They'd come to the local hospital for that ED visit. And here's what they told us their top desires were related to healthcare. One, they want more options locally for same-day access, for walk-in care, after-hours care. They don't want to have to go to the Dalles or other places at 8 o'clock at night, is what we heard. They want more specialty care. If you can do it, they want that care provided locally because they want to not travel out of the area so much. And they also told us that they wanted better access to pharmacy services. So those were the 4 key takeaways from that process. And the community also told us that they were eager to learn more about you. They wanted to know how you're performing. What are you doing to recruit and retain staff? We heard a lot about the turnover of staff, that people really like to have a constant staff. I hear that in every community, by the way. You're not alone, and in rural communities, it's a challenge everywhere. It's a challenge in rural communities. And they want to know about your providers, your staff, who these people are, and the kinds of care that they provide. And now let me tell you a little bit about the chamber survey. So as you know, that the chamber put a link out and asked people if they would answer, I think it's 5 questions. It was a very brief survey. I think they called it the 1-minute survey. And as of Friday, they shared the raw data with me. So when I say we, it's the chamber's survey, but I was able to take a look at the data and do some quick analysis on it. And what we saw here is, again, over 90% of the population was aware that there was an election on August 6th. 94% told us that they voted. So again, the people that are paying attention to this chamber 1-minute survey are pretty informed people in the community right now. 62% of those who voted in favor of the bond. And we all know the bond didn't pass, so we do know that the group that we're looking at is, again, has a different perception than the community at large had. And of interest, those under the age of 65 were slightly more, indicated at a slightly higher level that they had voted yes than the seniors. Typically we see some of that. I know seniors tend to have more concern about taxes, but we typically see that reversed. So you can see the data there. I'll get to the real results on the next slide. So of the 40 people that voted no, 36 told us, gave us reasons why they voted no. And here's what they told us. The number 1 reason was there was some kind of dissatisfaction with the hospital. Customer service, billing, staff development, staff training. Those were the kinds of themes that we heard. And when we met with the large group that we talked with last night, this issue kind of, we spent a lot of time on billing, and I think the hospital did a really nice job talking about all the changes it has implemented since April, I think I heard.
Yes, ma'am.
And people seemed to acknowledge, I heard acknowledgement that there's been some very recent improvements in billing. There was a smaller group that told us that they thought that the bond was not focused on the right priorities. These are really hard to separate. Not focused on the right priorities, not appropriate for the community, too expensive, fluff is the word we've heard a couple of times, or I've read a couple of times, or didn't demonstrate need. People are thinking that there are things, I don't know that there was enough information out there about the actual components. People talked about, last night, about the cafeteria, about the pharmacy, and just thinking that the project is too much for the community and wanting to see it right-sized.
In April, actually in March, we started a process to upgrade our current billing system, our patient financial system. So we've now got where instead of where in the past we used to push bills out and then our billers had to work at trying to figure out why it didn't get paid. Now, since the first week of April this year, the claim stops before we bill it. If the diagnosis doesn't support the service, whatever the case may be, we've got it coded, we have it, we're missing charges, things like that. Well, now the claim will stop ahead of time so that we have to fix that problem before it goes out to your insurance.
Only have enough staff to handle what we've got right now. And so, yes, we have outsourced some of our business, but it's insurance accounts that are 61 days and older, trying to clean up our AR for us so that we can focus to keep from moving those accounts further out for somebody else to have to take care of.
So taking a look at the data from 2009 to 2019, and I pulled August just to be a good comparison, and when we're looking at net revenue in the district from 9 to 19, which for someone like me, I've been at the hospital that entire time. 10 years has gone by really fast, and you forget kind of the growth that's happened throughout the district. But in that time, our revenues increased 37%. So then we've also taken a look at what does that mean for claims? What is that difference and significance that's happened in the 10 years that would affect the business office? And so with the claim growth, that's also been at about 20% claim growth. And so we're in a rural community, it's sometimes hard to recruit staffing in particular areas. So as Brenda was mentioning about having this company in Spokane, so one of the things that was really important to us, if we had to look outside of the district walls for some services and help for those services, was to have someone at least as local as we could be. We didn't want somebody overseas trying to call because that's usually very alarming for patients. And so there's a great company out of Spokane that works with a lot of rural communities. That's really what they focus on is business offices. In some cases, they take over business offices. That was not our goal. Our goal was not to outsource the entire business office, but to be able to have some support to help with some of these claims that we've had so much growth in. So right now, as Brenda mentioned, they are helping us with these claims that are older claims to make sure that they're getting worked, because there's some statistics out there, and I didn't bring those today, but there are companies out there, for insurance companies, that there's requirements for them to deny bills the first time that they come in the hopes that these rural small companies do not have the time to go back and do the appeal process to make sure that your insurance claim is processed correctly. So then it's up to our business office to go back and do those appeals for those patients. And that's sometimes where you see it can be a year before you receive your hospital bill because the business office has had to go back and fight with that insurance company 2 or 3 times. If you have a secondary, once we can't bill your secondary till your primary pays. So once we get that worked out with the primary, they then turn around and bill that secondary. And so this company is really helping us through that process to make sure we're getting those processed just as quickly as we can. We have 8 employees in the business office currently. Of those, 5 of them are billers. So they bill out and they collect on your bills. So this company also then helps us with private pay. So you'll be getting phone calls from this company in Spokane. If you call in, you'll call a 773 number. It looks like you're dialing right to the hospital. It forwards to this company. They have all the access to your company as though they were employed in-house to be able to help you. And the whole idea was so that it's seamless for the patient, that it shouldn't be any different experience for you if you're calling Brenda, who's housed right here at the hospital, which we call it 711, which is the old clinic, or whether you're getting the person in Spokane. The other data we took a big look at too, and as Brenda was mentioning, we added this new RCM process, which is revenue cycle management process, to make sure that these claims, hospital billing is incredibly difficult and complicated, and one of the changes that we've gone through between 2009 and 2019 is ICD-9 to ICD-10 coding. So I don't know if anyone's familiar with that, but we went from coding 13,000 codes to 68,000 codes. And so that makes a big difference when you're going on your bills, trying to take a look at them and make sure that they're as accurate as can be before they go out. And so those are some other changes that we've gone through and education of staff to make sure that they're just as accurate as can be before those claims are getting out. And so we do recognize that there's a few breakdowns in the system, and we're working very hard at correcting those processes, because we don't want you to come and have a great experience with your mammogram or whatever it is that you came for, but then get frustrated because your bill wasn't right the first time. So in Barb's case, I would ask that you give us a chance, and if you're having those issues, please know that Brenda or I are always available for phone calls. If we're out on vacation or off, our voicemail will tell you that, so then you can expect that you won't get that phone call in 24 hours, dependent on what our voicemail might tell you, but we are always available. And to make one other note of information that we took a look at. So also when we took a look at the percentage of denials from 2009 to 2019, in 2009 the percentage was 3.66% of denied claims, which means the claim was denied and then resubmitted. As of August of 2019, we're at 0.55%. Our goal is less than 2%. So we are really exceeding that goal. However, we wish we never had any denials, and we wish that we never had any complaints in the business office. But we are making some progress.
Can we address, Heather, your concern about a net operating loss?
Yeah.
It is a valid concern. However, we are 75% Medicare and Medicaid, our revenue comes from. And it's on a cost-based basis, and they don't cover all your costs. So I'm sure the state, Washington.
60% of all rural public hospital districts.
What was it?
60% of
60.
all rural public hospital districts in our state don't break even from operations.
So I've been here 10 and a half years. We've never, during that time, I don't think, except for with grant, we've had some different grant funds that have helped us overcome that. So we make up the difference with our maintenance and operation levy and with grant funds. We look for alternative ways to generate that revenue and make us whole. So it's just as a critical access hospital in a cost-based environment, the math doesn't work. The national average is just under 3 years that a physician will stay in the spot. We have beat that average, so it's good. We do recruit. We have Dr. Armerding here now. He grew up in Hood River, and he did part of his residency rotation and then came to work for us. So we work hard at recruiting. I'm sure MCMC is faced with the same thing. We try to offer, something different here than someone would get in the city, and sometimes providers are looking for rural locations that they don't necessarily want to work in the city.
On dental, I have spoken with Dr. Large, because before when we started the process with dental, we had Dr. Remke and Dr. Bryant involved in the process. They were very supportive of going forward with a dental clinic for those patients that don't have access to dental care now. And Dr. Large had the same position, and he was very supportive. And so I told him we get a little bit further along in the process, we'll invite them in. And we just kind of talked about what insurances that he accepts and doesn't accept, if he's seeing kids that are, Apple Health. And so I think that will be helpful in the future. And, when the dental clinic gets up and going, and I think the community will recognize that it's not in competition with the local dentists. We can stop people going for pharmacy. We can stop for some of those things that we can provide here locally. And you remember when there were 2 pharmacies before Larson's closed? There were 2 pharmacies, and in case
And I guess they paid their bills.
They could run across the street to Larson's and get your prescriptions filled, and it worked. And they complemented each other, and they were right across the street from each other.
They certainly were.
So that, and we're trying to fill those prescriptions that are written by our providers when patients are seen. So before you get discharged from the hospital, you can take your medications home. If you're seen in the emergency department, you can get those medications. The same day, if you go in for a UTI, then you can get that medication before you.
In the evening and on the weekends.